Welcome. We're starting off the season with a treat, a visiting scientist from the Washington University in St. Louis. Dr. Stacey Rentschler is a professor in the departments of medicine, division of cardiology, and developmental biology. She's a true translational scientist, deeply involved in basic research as well as an active clinician. She is extremely well published in high-profile basic science and translational journals. Her area of interest is in dysrhythmias, ventricular tachycardia fibrillation, and that's what she's going to talk to us about today. The title of her talk is From Cells to Rhythms, How Cardiac Reprogramming Advances Arrhythmia Therapies. Welcome, Dr. Rentschler. It's wonderful to have you here in Calgary. Thanks.
Thank you so much for the kind invitation. And I see Rob at a lot of conferences, and it was really a pleasure to be invited here today and meet all of you in person. And I know some folks here are working on radiation as a treatment for ventricular arrhythmias as well. So I welcome any suggestions or collaborations. Let's see. There we go. So I'll start by thanking the people who did the work. At the top here is physician scientists at multiple different stages of training. David Zhang was the first student in my lab to take on this project, and I'll show some of his work today. Brian Zenger is a cardiology fellow, also a physician scientist, and then two others who I'll show some of their unpublished work as well. Sherwin and Sam, so they're bright stars, up and coming in the field. And then also I'd like to thank the Center for Non-Invasive Cardiac Radiotherapy at WashU. I have really great colleagues there. Many of you may know Phil Kukelich and Cliff Robinson, who were the first brave folks to take on treating patients, or the second, but they did the first case series. So I owe a lot of this to their innovation. And so I'm going to talk today about using cardiac radiotherapy, and I'll say here cardiac radio ablation in quotations. The concept was initially to use the same strategy as treating lung cancer, but to actually aim the beam at the heart. And Phil and Cliff were asking whether a single non-invasive radiation treatment could safely reduce VT burden in patients who had already failed conventional therapy. So the thought was that they would use radiation instead of a catheter to create an ablation scar in the heart. And this was based on some preclinical data that was done in a porcine model, and this was done in the atria. And shown here, this is escalating doses of radiation. So the radiation is measured in gray, and this is time. So this is over time, and the follow-up here was 6 months. So at these high doses at 6 months, you can see here the amount of fibrosis that is generated. So this is a trichrome stain. Red is surviving myocardium, and blue is scar. So at doses of 50 gray 6 months later, you can generate a significant amount of scar in the heart. And then you can see here at 25 gray, you see this kind of, mild to moderate scar tissue form after 6 months. So the initial dose that was used in humans was 25 gray, because first in human, do no harm, right? And the thought was, well, it can create some scar. But if you can see like what a catheter does, it does not look like this, right? When you do a catheter ablation, it looks like more full thickness scar. So keep this in mind. So this was the first data. And the very, very first patient was treated at Stanford. And then the next 5 patients were treated at WashU. And this was published in a case series where this is the number of ICD discharges per month. And then this is the treatment time. And you can see that it takes a little bit of time. So the blinding, the blanking period was 6 weeks. And then after that, all of these 5 patients had complete cessation of their VT. And then the next phase 2 trial, which was also at WashU, this is the number of ICD discharges prior to radiation, and then this is post, in the 6 months post. So you can see that some patients had complete cessation and others had a reduction of their VT burden. And then these results were subsequently replicated at many different centers across the country and across the world. And again, the postulated explanation was that 25 gray can cause cell death and fibrosis and act, in the same way to ablate like a catheter. And so I just wanted to mention that now there's a phase 3 clinical trial that's going on in the US. It's sponsored by Varian. It's called Radiate VT. So I know that there's different trials going on, here in Canada as well as in Europe. So the one in the United States is called Radiate VT. And it's comparing cardiac radioablation versus catheter ablation. And so these are high-risk VT patients, either ischemic or non-ischemic. They have to have a reduced ejection fraction, and this was modified from, less than 30 to less than 49 because of, recruiting more patients. So all of them have previously underwent at least one standard of care catheter ablation. All have an ICD. They're all technically a candidate for repeat catheter ablation, and they have all failed amiodarone or cannot take amiodarone. And so they're randomized 1-to-1, and then we're in this phase of enrollment here, and then there'll be a long-term follow-up period as well. And there are many sites that are open for enrollment. This slide may not be current, but these were the initial sites that enrolled. As part of this study, and I'll mention this because I know Rob is working on this here as well, we have a biomarker study as well. And so we are collecting blood at baseline immediately post-treatment within the first 24 hours, day 3, week 6, 6 months, and 12 months. This is in collaboration with Varian. And at WashU, these are the different assays that we're looking at. So a lot of the immune pathway, as well as microRNA profiling. And we have some preliminary data on the microRNA from the first phase 2 trial, actually, that's going to inform and hopefully replicate in the Radiate VT trial. And then Varian will be looking at different immunoassays, cardiac injury markers, fibrosis markers, and such. So I don't have data to show you today about that, but I just wanted to mention that that's part of the ongoing study. So what are the different ways that you can treat ventricular tachycardia? So I just kind of want to talk about, underlying mechanisms and, how we go about treating it. So in a normal heart, everybody gets PVCs, premature ventricular contractions. They can have block in one direction. And in a normal heart, as that goes around, it'll conduct normal. And when it gets back to the site of origin, the tissue is repolarized and not repolarized, it's refractory. So then you just get one beat and it stops. Okay. So the tissue, it conducts normal, it's refractory, it stops. But in a diseased heart, you can see slowed conduction through this pathway. And so in the diseased area, so it's traveling very slowly. And when it gets back to that initial site of origin, the tissue is now partially repolarized, so it can continue around in that loop. And then you get this cycle of around and around, and that's reentrant ventricular tachycardia. So there is, 2 kinds of ventricular tachycardia, the automatic versus the reentrant. So I'm talking here about reentrant tachycardia. And so what causes this slowed conduction? Well, of course, diseased hearts have a lot of fibroblasts. And it's really thought, people can see the fibroblasts and, that's the be all end all. But actually, what happens in diseased hearts is near the regions of fibrosis, you have downregulation of ionic currents like the sodium current, as well as gap junctions in that surrounding area. And that's actually even more profoundly disturbing to the conduction and the conduction speed. And so this is just an in silico model here where the sodium current has been reduced within this isthmus area. And just to show that without any fibrosis, by reducing the sodium current within this isthmus, it can generate reentrant cycles. So in all computational models, the addition of fibrosis alone is not able to sustain a reentrant circuit. You have to also have these disturbances within the myocardium as well. And so that'll become important as I talk about like what are the mechanisms for this treatment. So what do we do when patients have reentrant VT? Well, many people on this call or in the room, I'm sure, do ablations, and the goal of the ablation is to destroy that path, destroy the tissue, homogenize it, get rid of those, islands of surviving myocardium. And so here we're destroying tissue in an already sick heart. And sometimes it's very challenging to get to the place where these circuits are, right? They could be, in the mid-myocardium, for example. So it's tough to get there. And then we also can treat patients with class 3 antiarrhythmics, which can prolong the refractory period. So then as this reentrant tissue, the slow conduction is going around, it now finds that the tissue is fully refractory when it hits there, because we've prolonged the effective refractory period. And finally, a theoretical mechanism would be to speed up the slow conduction. And, that was the problem in the first place, right? But up until now, we didn't have any way of actually doing this therapeutically. We had no drug or treatment that actually, speeds up conduction. So I'll show you in the first part of my talk that, some data that suggests that radiation could actually potentially do exactly that, and actually speed up the conduction in the abnormal tissue area. So when I first got involved with this project, I was at dinner with Phil, and he said, we treated these first couple patients, and they had remarkable efficacy, and I don't know how it works. Could you help? And so the first thing I did is say, okay, well, we have some patients who've expired or had a heart transplant, and so let's look at the patients and see if it's causing fibrosis. So this is, again, those first couple of patients. The red is surviving myocardium, and blue is scar tissue. This is a trichrome stain. And so we looked in the remote area and in the targeted area. And I hope you can see that, there's, it's no dramatic change there in the amount of blue. And just to compare, this is what a catheter ablation does. You get this full thickness, scar tissue, right? So no surviving myocardium. And so every patient has its own baseline starting point of fibrosis. So this was just kind of quantifying the scar. So if you could see the very different amount of scars. And then this is in the remote versus targeted. So it's not over time, but it's just looking at the regions that got the lowest dose of radiation and the highest dose. And yeah, there might be a tiny little bit of change, but it's not really that dramatic. This is what a catheter ablation looked like in this same patient, where you can see this really marked increase in fibrosis. So I want you to contrast that with, this is how many ICD discharges these exact patients had. So some of these patients were having more than 150 ICD discharges per month, and it went all the way down to 0. So based on this, we said that fibrosis alone cannot account for this dramatic efficacy. And then this is also just showing the MRIs from those same patients, where the red region here was the highest dose, the targeted area. And you can see here in yellow, these islands of surviving myocardium at baseline. And we still saw those areas 3 months later. They didn't change markedly. So based on this, we thought, okay, fibrosis alone is not the only answer here. So if it's not fibrosis, what else could it be? So we then developed a murine model so we can start to ask these questions in collaboration with radiation oncology and Julie Schwartz's lab. We used the small animal radiation research platform, and we irradiated the heart with 25 gray. So one difference in the mice is that when you give 25 gray, you're giving it to the whole heart. It's a very small, heart. It's hard to give sub-volume doses, like I want to target the LV, in the mouse, right? So in humans, when I say 25 gray, there's a region that's getting 25 gray, but there's other areas of the heart that are getting less than 1 gray, and I'll show you that later. So in this case, the entire mouse heart gets 25 gray. And then we waited 6 weeks because that was the blanking period where they measured clinical efficacy. And then we looked at the tissues, EKGs, and electrophysiology. And we found that, again, this is controlled, this is irradiated, and this is, again, that same trichrome stain where blue looks at scar tissue. And I hope you can see there's very, little, if any, scar tissue in these irradiated hearts at 6 weeks. So then we asked, are there any functional changes? And this is an experiment where we did optical mapping using a voltage sensitive dye. So this is the control heart here. This is the irradiated heart. And, this is the pattern of activation across the hearts. So I'll show you, we stimulate, and I hope you can see that this heart activates faster than the control heart. So these are normal, healthy hearts that we've given radiation, and we can speed up conduction faster than nature has made it. So that was pretty cool. But we don't give radiation to normal people's hearts, right? We give it to diseased hearts, right? So we see it speeding up in a normal mouse, but what about in a diseased mouse? So this is just quantifying. We saw the speed go up in the longitudinal and transverse directions from about 60 centimeters a second to 80 centimeters a second. So what are the molecular determinants of conduction, and why might this be happening? So myocytes are coupled to one another through gap junctions. Connexin 43 is the predominant gap junction in the ventricle. And also the speed of conduction is determined by the sodium current, and NaV 1.5 is one of the subunits of the sodium current. And we saw that both NaV 1.5 and connexin were also upregulated, coincident with the conduction speeding up. So we think that, we saw the molecular determinants of increased conduction going up. Next, we looked in this diseased model, and we tried multiple disease models, but I'm going to show you this one because we're able to learn a lot about which cells are being affected in the heart because we did a permanent LAD ligation. So everything distal to that is scar tissue. So you have, surviving myocardium here proximal to the LAD ligation, and then distally, this was a permanent ligation. So this is all scar tissue. And we let the scar mature for 2 weeks, then we gave 25 gray, and then we did the same optical mapping experiment. So this is the MI alone, and then this is the MI plus irradiation. And in this case, if we would stimulate the scar in either case, we didn't capture it. So the radiation didn't actually, change the electrical characteristics of the scar. If we stimulate in the healthy tissue above the scar, we didn't see it propagate, substantially into the scar, and we can quantify the speed. And same thing after radiation, we didn't see it propagate down into the scar, but if you can see here, the speed is faster. So the blue areas activate first, followed by green, yellow, red. And you can see there's a lot more yellow and red in the untreated hearts than in the treated hearts. So it speeds up conduction in the surviving tissue. So it does not modulate the scar. And so we also, I'm not going to show you here, but we, took the scar and dissected it and looked at expression of connexins and sodium channels. We didn't see any changes within the scar tissue itself. So we think it's actually modulating the healthy tissue or the surviving tissue. So to get some idea what might be happening, we first performed RNA sequencing to look at the changes in the transcriptome. And this was published data from a few years ago, not at the single cell resolution. This is just the global. But when we did this, we saw a lot of different things changing, and again, there was different time course to these changes. So at 2 weeks and 6 weeks, different pathways were turning on. And I actually didn't mention this, but the electrophysiology was changing from 2 to 6 weeks also. So it's not an immediate effect. This is kind of something that takes a few weeks to develop. And one of the pathways that came up here is notch signaling. And I had been studying the notch pathway for about a decade. And at first, my colleague was like, I was definitely avoiding studying it in this context because it's like, well, that's bias. And it kept coming up on every screen. And so my colleagues like, you just need to just ask it, right? So the notch signaling pathway is a cell-to-cell pathway. You have a ligand that's on the sending cell and the receptors on the receiving cell. And when that engages, this receptor gets cleaved, it goes into the nucleus, and it affects transcription. And so we looked after, this is in an in vitro model, we irradiated cardiomyocytes in a dish, and we found that this is sham, and then this is irradiated cells. The ligand starts to become expressed by 4 hours, and then you can see after that, the cleaved notch receptor becomes activated. So again, this will go up, and then the notch receptor will get cleaved. So notch is being activated in cardiomyocytes after radiation. And so we then asked, what does transient notch activation, like mimicking a blip of radiation, do in mice. And so we developed this transgenic model. It's called a TET-on model, where we can give the mice doxycycline chow and it'll turn on notch signaling in cardiomyocytes only. And then we can remove the chow and then we can see what the effects are up to a year later, or however long the mice live. A year is about half of the lifespan of a mouse, so that's a very long time. So we did this and we found that if we do optical mapping 1 year after we've given this blip of notch signaling, the conduction velocity is still increased. And so I will say it wasn't at the same magnitude as radiation. Radiation had a more profound effect, but we did see that it was consistently upregulated even 1 year later, suggesting that the switch is flipped, right? And so this is the definition of reprogramming. If you have a stimulus, and that stimulus then goes away and the phenotype persists long after the stimulus, that's called reprogramming. So we think that partially through notch activation and other things that radiation is reprogramming the cardiomyocytes. And so then we did the loss of function experiment where we inhibited notch signaling in cardiomyocytes to see if it can attenuate the radiation effect. And I won't get into the specifics here with this animal model, but we used the dominant negative to block notch activation in the cardiomyocyte. And then we, after blocking notch, we then irradiated those mice and we did the same experiment. And we saw that there was a less strong upregulation after radiation. So these are the control mice after radiation conduction velocity, and these are the notch inhibited mice. And we saw that the reason why is that the sodium channel was not as significantly upregulated. So we saw that notch can upregulate the sodium channel, but not connexins. And that if you inhibit notch after radiation, you don't see as profound upregulation of the sodium channel, but it had no effect on the connexin expression. So there's more to the story than notch, but there's partly notch dependent. And then finally, everybody asks, well, this is a mouse and is it relevant to, a human? So there are some things that are conserved in mice and there are some things in human physiology that are not conserved, but the conduction is one of those things that is conserved from mice to large animals to humans. And so we then wanted to ask whether we could actually see an antiarrhythmic effect in the mice that coincides with these changes in conduction. So we did, in this case, a closed chest ischemia reperfusion model, because this is what's more similar to in human, where you have your heart attack and then your artery gets opened. And so it's not, it's a mix of a scar and some healthy myocardium, surviving myocardium. We allowed the scar to mature for a month, and then we irradiated again with 25 gray. And then 6 weeks later, we did in vivo programmed electrical stimulation. And this is what that looks like in a mouse. So for human EP people, this is not such a huge, amount of VT, but this in a mouse is a pretty, this is significant VT. The heart is smaller, so it's harder to sustain as much VT. But we saw that in the sham mice, we could induce VT in 5 out of 6, but there was no VT in the treated mice. And the severity of the arrhythmia was also lower. So coincident with these changes in conduction, we also saw an antiarrhythmic effect in the mice. And then we tested lower doses because can this effect be achieved at lower doses? So we did a dose de-escalation. So this is 25, 20, 15, 10. And we looked at the QRS interval, conduction velocity. So you can see that there was a dose-related decrement here. So 20 gray had a similar effect to 25. 15 was still statistically significant, but a little bit biologically less, right? And then, as you go down in the dose, you go down in the conduction. And that was coincident with upregulation of the sodium channel and connexin. So there were, it's very dose dependent. So the higher doses had more upregulation. So to summarize this part of the talk, we found that 25 gray can increase conduction velocity partially through increasing the sodium channel expression and gap junctions. It activates notch signaling, but we didn't see evidence of fibrosis. We saw that it's a long-lived effect out to 1 year. If you could give lower doses like 15 or 20 gray, you can still have the same effect. We used an injury model to show that where these properties are being modulated is in the border zone or the surviving myocardium, not in the scar itself. Notch activation was sufficient to increase conduction velocity and upregulate the sodium channel, and that effect was long-lived, consistent with reprogramming. And then if we inhibit Notch, we can also inhibit partially the effect through inhibiting upregulation of the sodium channel. So what about in people? So in people, we give one dose of radiation, and we can see that, and this is going back to the phase 2 trial, looking at the median VT episodes in the 6 months intervals after the treatment. And we can see that, it's persistently downregulated. And this, I don't believe is published, but was presented at the Astro meeting in this abstract. So it's a long-lived effect, right? So we started to think, like, what are the different things in the cell that can account for such a long-lived effect, right? Things turn over in the cell. So this got us thinking about that, and I'll get back to it later. One of the things that is, cells can have a memory for a long period of time is epigenetics. And so that's where this idea came from, is like one dose of a treatment, and how could these effects be so persistent? This is out to 60 months, right? And we have like 5-year data now. So one of the things we looked at was, we had one patient who received a heart transplant. And so we were able to procure the heart, because they had, their VT went away, but they had continuation of the heart failure, and they got a heart transplant. So we could actually preserve the tissue in such a way that we could do molecular studies like Western blotting. And so this is how we represent, the heart here, the LV, in the 17 segment model. And I'm showing you here in red the area that was treated with 25 gray, or the highest dose. And then this was the furthest away area in region 10 in the heart. And so we wanted to first compare expression of the sodium channel and gap junction in non-failing hearts in those two different regions. And we see that there's no difference in the two regions in a normal heart. In a patient with heart failure in the untreated region, this patient had downregulation of the sodium channel, but in the area that was treated, it was actually even higher than in normal hearts. And I'm going to stress that this heart was explanted 960 days after that dose of radiation. So this effect on the sodium channel persisted for that long after. And in this particular patient, we did not see any changes that late in connexins. So I'm not sure if the connexins went up and down, or they just didn't change and there's heterogeneity. This is an N of 1. So, much still to be learned there. So next, my student Sherwin wanted to kind of get a more global picture of what are all the different changes happening within the hearts. And one of the things we did, and we started in the mice, we looked at single nuclear RNA sequencing to see what are the different cell types that are changing, as well as, in which cells are the gene expression changes occurring. So he did single nuclear sequencing 2 weeks after 25 gray, shown here. The irradiated cells are shown in red, and the sham in green. And these are just the labels of the different cell types. And what I wanted to just show you is that at 6 weeks after radiation, we saw a lot more changes, and the changes occurred within cardiomyocytes. So you can see by 6 weeks, the treated cardiomyocytes did not overlap at all with the untreated. There were changes, a lot of changes happening within cardiomyocytes. And in addition, we saw that there were new leukocyte populations like here that came in, and a lot of macrophages that weren't present in the untreated. So all of the cells cell types had some gene expression changes, but the major changes that we found were within the leukocytes and the cardiomyocytes. And so it's very interesting that pathologists can look at tissue and say, oh, this tissue has been irradiated at some point in the past, because they have this term called nuclear smudging. And so we wanted to ask whether this nuclear smudging was happening in hearts that had been treated with radiation, because in the past, before this, radiation oncologists avoid hitting the heart at all costs, right? So there's really not a lot to, before this to see. So I'm looking here at the targeted versus remote region, and then an unirradiated human heart. And I hope you can see, it's a little small here, but the shape of these nuclei in the irradiated areas versus in the unirradiated, they're they're just smudged, right? They're just kind of weird shape. They're not rounded like, yeah. Oh, sorry. Is my pointer not showing up on here? Okay, sorry. Let's see. Thank you. I didn't realize that I'm pointing here and that you're not seeing. Okay, so this is the irradiated nucleus here. You can see that the nucleus is irregularly shaped when compared with the unirradiated here. And so we then asked in the mouse heart, we irradiated the mice, and then we wanted to kind of understand what is underlying these nuclear changes. So we did FANS sorting. So we take the nuclei out by sorting using this marker called PCM1 that can pull out the cardiomyocyte nuclei. And we can look at the DNA content. And we saw there was no change in DNA content, because one of the things that can happen in cardiomyocytes is that the nuclei can actually go all the way up, and they can have 4N and 8N and 16N, especially in disease states. So we didn't see any changes actually in the content of DNA, but we did see an increased nuclear size in all of the nuclei, as well as the cardiomyocytes and the non-cardiomyocytes. So irradiation changes the nuclear shape and size. So I mentioned before that one of the things that can cause persistent changes in a cell are epigenetics. So we wanted to ask whether, based on knowing that, as well as the fact that the nucleus is changing in shape, there are a couple things that can change nuclear shape. You can have, structural changes, like actin filaments can be pulling the nucleus out, or you can have the chromatin within the nucleus as actually, kind of packaged differently. And so we started looking at the packaging of the chromatin within the nucleus. And I'll just keep this very high level. This is looking at the RNA expression. So these are the male and female. This is a PCA plot. So this just shows you in general, all of the RNA transcripts in the cell, do they cluster together? So you see here in red, the untreated versus the treated cluster separately. And actually this is male and female. There's a lot of baseline differences in the RNA between male and female. And so we saw a lot of genes here go up after radiation. And then we looked at the areas of the chromatin that are closed and open. And we did that using this technique called ATAC-seq. So I'm happy to explain it to anybody who wants to know later. But basically what this looks at is the areas of the chromatin that have been opened or closed. And we found that after radiation, so this is looking at 2 days after and then 6 weeks. So a lot of genes go from at a low level expression here in blue, they go up and they come back down. And then there's some genes that start high, they go down and they go back up. But very interesting are these groups down here, for example, in blue, that starts out low, gets higher, and then even higher at 6 weeks. So again, I mentioned this reprogramming effect, right? It's something that's persistent. So there are some regulatory regions and RNAs that are actually going in one direction. And so this is going up, and then this other smaller cluster is going down. And we then looked at some of the categories of the genes that are in that and found that many of them regulate electrophysiology, like membrane depolarization. We found that there's certain motifs for transcription factors that are enriched within these areas that change. And we found that it's throughout all areas of the genome. So, gene regulatory, transcription start sites, it just kind of blasts everything, right? Radiation is hitting the cell everywhere. And so, again, this is what chromatin packaging looks like, in areas that are very tightly packaged. If you have regulatory regions where transcription factors bind to turn on gene transcription and it's packaged very tightly, you can't, the transcription factors can't access that, so the gene is turned off. But then you can have histone modifications that open up that chromatin, and now the transcription factor binding site is more open and it can be bound and expressed. And interestingly, when we looked at these regions that I was mentioning, in these areas that are opening and closing, we found that many of them are near ion channels. I don't want to say that they're all near ion channels, a lot of different types of categories, but we found that, these are a lot of sodium channels, calcium channels, and then as well as basically potassium channels, every channel, a lot of ion channels. And I'll just give one example, looking at SCN5A, which is the gene that transcribes the NaV1.5 protein, which makes up the sodium current. We found that near the transcription start site, we had areas of increased accessibility 6 weeks later. So this is like at baseline 2 weeks, but then it opens up even more 6 weeks later, coincident with upregulation of that protein. So then we were asking a lot of these questions in a mouse model. We wanted to then move to a human stem cell model because, it's, we can ask different questions, and, we then wanted to ask whether this effect is cell autonomous to cardiomyocytes. So here we've taken away all the other cell types. This is plating induced pluripotent stem cell cardiomyocytes. These are sham, and these are cells after radiation. And we looked at the conduction velocity using a multi-electrode array system at multiple time points. So you can see the day 1, day 7, 14, and 21. And so we didn't see any increase in conduction speed at day 1, and it starts to increase by 1 week. And then over time, that increase gets more. So this is looking at the actual number, and then this is looking at the percent change. So if the longer out you go, the faster it's going. So this is a phenotype that's progressive over time. And so the fact that we can replicate this with a dish of only cardiomyocytes means that this phenotype is at least partially cell autonomous to myocytes, right? So it means that you don't need the immune cell to get the conduction change, right? I'm not saying that the immune cell isn't doing something, but in this case, we know that there is a direct effect on the cardiomyocyte. And I'll go really fast over this. We did the very same kind of chromatin changes, and we saw that there's all different, types of patterns, like genes go up, down, up. And, we saw epigenetic changes that coincide with that. And so then, one might ask, well, radiation, does a lot of things to tissues. One of the things that is remarkable is that in a dividing cell, or a cancer cell, it will cause mitotic catastrophe and cell death. And it uses a different DNA repair strategy than non-dividing cells, which primarily use non-homologous end joining repair to repair DNA damage. So we wanted to ask whether it's the DNA damage itself that might be inducing this change, right? Because you get a lot of reactive oxygen species, a lot of things happen after radiation. So to ask this in a very, kind of high level way, we thought, okay, are there any other ways that you can induce DNA damage? For example, bleomycin. This also can induce ROS, so it's not as clean as some of the other DNA damaging agents. But we looked at whether this is 25 gray treated cells. We look at gamma H2AX, which is a marker. It's a histone marker of irradiated, when a cell has been irradiated. And we wanted to find a similar dose of bleomycin that could create the same amount of damage. So 100 micromolar was like a massive amount of damage, and 10 micromolar was about the same as 25 gray. Keep in mind, these are not physiologic doses of bleomycin. Bleomycin is a drug that we use to treat, in people, but these are doses that would kill. This is just to ask whether DNA damage could induce it. Then we looked at conduction velocity, and we saw that the 10 micromolar bleomycin actually increased conduction speed, to a maybe slightly less degree, but still, this is comparing it with the 25 gray radiation. But then by 100 micromolar, the cells started to die, so the speed was a little lower. So DNA damage alone seems to be doing something, and we're currently investigating like the DNA repair process, and that's active area of investigation in my lab. We also make these engineered heart tissues. This is an engineering student who is making these dynamic engineered heart tissues, as shown here. And I like these tissues because they get to near physiologic stress and strain levels, similar to like human myocardium. And so we irradiated these tissues and measured conduction speeds. So in the untreated, it was about 10 centimeters a second, and in the irradiated, it about tripled. So, okay, so that's the the human-induced pluripotent stem cells. Now I'd like to, in the last part, and I don't see the clock, but I don't know how much time I have left, but 15? Okay. So I'm going to tell you about our work in the translational work in pigs. As I mentioned, there are just some things we can't test in the mice. The heart is small and we can only deliver one dose. But in humans, I'll show you that when you target with a dose, you actually get a range of doses across the heart. So for that reason, and also the fact that pigs have they're more similar in repolarization to humans than mice are. So we developed a large animal model where we create an infarct using a catheter to occlude the mid-LAD. We allowed that to mature for 6 weeks. We then performed a baseline MRI and ECGI. Then we irradiated, and then we waited 6 weeks, performed another MRI so we can compare the cardiac function and the amount of scar tissue before and after. And then we did an invasive electrophysiology study. And this is a representation of one of these pigs so that you can see the scar tissue here. So it's a decent sized scar that we're actually making in these hearts. And so then we delivered the dose, and the prescription is 25 gray to the PTV. And I don't know if there's any radiation oncologists on this call, but I really wanted to show this because there are other institutions who are delivering 25 gray versus our institution. And so the blue is the way that we deliver 25 gray to people and to our pigs. And the red is the way another institution is delivering it. And so the way the physicist does the treatment plan can markedly change the actual prescription dose, right? So, this is basically showing the absolute gray. So as it goes up, it's a higher dose, and how much of the heart is receiving that dose when you treat it without a hotspot, and then our institution does a hotspot. And so I asked, why this variability? And to my understanding, some people who are thoracic trained and they treat lung cancer as their primary job, they believe in hotspots, get that hotspot, kill the cancer cells. And then if you're not thoracic trained, they like to have this very defined, it doesn't go above it. But when you get 25 gray in this way, the regions are very spread out. So you'll get a large region of 25. And in this case, you have a very rapid dose fall off. So just to show you here, in our pigs, at the scar area, so this is, the representation again of the apex of the LV, there is actually a small percent of the heart that gets 40 gray when we prescribe 25 gray, okay? So that's within the scar. There's actually 6.7% of the heart that gets 35 gray, right? That's a lot, okay? There is 15% of the heart is getting 25 gray, 25% of the heart is getting 12.5 gray, and 40% of the heart is getting 5 gray. So I think this is really important, right? This is not just one dose to one area. This is a prescription that can change. And as cardiologists, we need to be very aware of that, because how you prescribe these doses, you can basically have the physicists, deliver it in different ways. And I think that number one, I think that might end up mattering based on what I've shown you about the dose de-escalation, right? And number two, I think it might actually create some, controversy in the literature if it's not fully understood that somebody says, oh, I treated with 25 gray. Well, it's more nuanced than that. And if we don't kind of understand that, yeah, maybe those results are both correct, but the way you treated with 25 gray and the way I treated with 25 gray could be very different. So the first thing we asked is, we're treating Yorkshire pigs that are continuing to grow throughout the experiment. So we didn't know whether the heart would even grow after you irradiate it, right? So these are juvenile pigs, and we saw that in fact they grow just fine. Again, cardiomyocytes, the growth of the heart in the juvenile stage is through cellular hypertrophy, not through dividing more cardiomyocytes. So the hearts continue to grow. I say that because actually somebody asked us, could we treat pediatric patients with this? And I'm like, I don't know. The only data we have is showing that the heart will still grow in pigs, but I think that's a little bit still a stretch. But okay, then we looked at the scar. So this is just to show you an MRI of what the scar looks like here, and we can measure contractility. We looked at the percent change in the scar, and this is 0, and this is -1 and -2. So these are very small changes, but if anything, there was less scar after 6 weeks in the treated pigs. And if anything, there was a trend a little bit upwards in the ejection fraction. Again, not statistically significant because this is a very small number, 3 and 3. Then Tim Smith, who's one of our clinical electrophysiologists, did stimulation at 3 different locations, the RV apex, the RV outflow tract, and the LV apex. And this was, for a couple of reasons, to induce VT. So I will mention that in humans, after we treat with radiation, we don't then go back and do a NIPS or any kind of invasive study. So we don't know whether these human patients are still susceptible. None of the pigs had spontaneous VT, we don't think, after the radiation because we didn't have any death. And usually it's lethal if they would have it. So when we were actually able to induce VT in both the untreated and the treated animals, and we didn't see any differences in, for example, a single extra stim, double, or triple. So they're still inducible, but we found is that when we looked at the refractory periods in the RV apex, RV outflow tract, and again, the LV apex is where the higher doses get delivered, we saw a really prolonged refractory period there, which is really regional and very specific. And it was like, whoa, that's a very big change. And it was, again, regional, suggesting dose dependent. And that corresponded to changes in the VT cycle length. So the cycle length was actually longer in the treated pigs than in the untreated. And this goes along well with what's been seen in patients. This is published by the Swiss group, looking at when patients get recurrences of VT after STAR, they occur outside of the treated volume, and they're actually easier to ablate because the cycle length is longer and you have more areas to go to ablate the VT. And so we wanted to ask why that might be the case. And so we partnered with Pat Boyle at the University of Washington to do some very simple, starting out with some simple computational modeling. So this is just a simple ring model where we're delivering a premature stimulus here. This is normal healthy tissue and this is unhealthy tissue. So the speed here is lower. And basically, this is going to play through the loop. So when we stimulate, it blocks in the lower pathway, but it can keep going around. Okay, so we can kind of interrogate whether we make changes in this treated area, when can we eliminate VT? And so he found that in smaller rings, VT was only inducible. So he prolonged the refractory period by inhibiting these 2 specific channels. And we found that we can eliminate VT in the smaller rings, but the larger rings still had VT. So this makes sense, for what I was trying to, let me just skip ahead for a second. To explain that here's a scar, here's the VT circuit. When we irradiate in this red area, we now eliminate the VT circuits that are inside the treated area. And then but we can still see that there's VT outside of that treated area. And so now what we're doing is we're using these computational models of our pigs to induce VT and then apply what we know from the biology on top of that to see, to predict what will this treatment plan do in this particular animal. So with that, I'm going to say that in summary, we think that radiation, we know that drugs like amiodarone can prolong the refractory period, but they have a lot of toxicities. Catheter ablation can ablate these arrhythmic circuits, but we can't always get there. And again, these patients have failed VT catheter ablation. That radiation can, it looks like, both increase conduction and refractory period in a focal way, which is kind of what an ideal antiarrhythmic drug would do. So beyond VT, there might be additional cardiac applications. These same patients, the very same patients that I just showed you, again, this is the dose distribution across the heart. So you can see that there are areas that get 1 gray, right? There's areas that get 5 gray. So the average dose was 5 gray. These patients had changes in their ejection fraction that increased at 3 days and 3 months by MRI. So the 2 of my colleagues at WashU asked whether these lower doses of 5 gray might attenuate adverse cardiac remodeling. And they used animal models and showed that 5-gray, when delivered early after the insult, can actually attenuate the decline in EF, and that's shown here. And so I think that, there's a lot to learn about this, but again, 5-gray delivered when you're already a remodeled and injured and LVAD type scar is a different thing. But it may be useful also thinking about other intractable heart diseases. Like here, there was a patient that was treated at WashU who had DTGA with an LVAD and was having a lot of heart failure because they were in VF. They were actually treated with 10-gray to the entire systemic ventricle. They were then able to defibrillate out of VF, and the patient lived another 9 months without VF. So there may be other applications outside of treating VT. And then we're studying that with a group of colleagues in single ventricle patients. And so I'll just end with a picture of the conference focused on radiotherapy. Now I hope you'll see why I'm calling it radiotherapy and not radioablation, because I think we are actually modulating the properties of the tissue, possibly reprogramming the tissue. And this is some of the investigators around the world who are working on this. And I thank you for your time and attention.
Thank you for that wonderful talk. We will open, I will unmute the room. So we'll open it up to questions, questions in the room or people online. You can either speak up or enter it into the chat box. Rob, why don't we start with you?
That was fantastic, Stacey. Thank you very much. So, just curious about this sodium channel effect. Looks so fascinating, and in some of your profiling work, it looks like you've got some changes in possibly beta subunits and some other things as well. So, looks like you focused on sodium, or let's say NAD 1.5 protein abundance. But do you think there's other things going on there? Are there changes in subunits that affect sodium channel trafficking or biophysics of the sodium channel to change the activation or inactivation kinetics? How complex is that effect?
Yeah, really great question. Thanks for that. So Rob is asking about the sodium channel and whether we've looked at other than, increased protein levels. So we do see changes in, the different subunits. We did one experiment, and I'm not showing it because, it wasn't publication quality data, but we saw that the peak current goes up in stem cells that were treated. And we didn't see changes in the inactivation or activation curves, but it wasn't, it needs to be repeated. So it could be all of those things. We don't really have a good handle on it. As actually Isabel, who is part of our group, is actually doing that in stem cell derived cardiomyocytes. But what I can say is that coincident with the upregulation of the protein, we actually did do like membrane fractionation and immunofluorescence. And it's not just upregulated in the cell, it is making it to the membrane, at least in the mice. In stem cell cardiomyocytes, they're a little bit more immature. So I think I'm not sure, and it's something that we really haven't dug deep yet into all the kinetics of the channels. I also do know we looked at calcium, and there are changes to calcium as well. We did start with whole cell calcium, and now we have to go and do all the hard experiments. So there's still a lot to know. This is just like dipping our toe in. So there's a lot of room to learn a lot of things. So there's a comment from Vic in the chat. Thanks for the presentation. We've done STAR on 4 patients for a local study, planning to take part in CARA VT Canadian study based out of Ottawa. So yeah, there's a great, a lot of things going on here in Canada. I think there's also some different dosing that's being delivered here. Not just the 25 gray, but also testing lower doses. We're more constrained to only giving that 25 gray dose in the US. I think the FDA did approve 1 dose de-escalation, but you know, I know that there's a lot of things going on in Europe and here in Canada, and, you know, it'll be very interesting to see in people, you know, how these different dosing strategies and compare. And I just encourage everybody to really partner with the radiation oncologist, because again, you know, it's really easy as a cardiologist to say 25 gray, but I hope I convinced you at least a little bit that how you prescribe that dose matters almost as much as the number, right? Or maybe more than the number. And so I can foresee that, like, if different centers get different results, right? Keeping in mind the dose prescription, but also the patient selection, right? Because some of the things I didn't show are that, you know, it also is modulating the nerves. And so if you're doing this in patients who've already had, for example, I know at dinner we talked about how some patients get, you know, a sympathectomy, and now you're doing radiation after that. Well, you know, you're sub-selecting for an even sicker group of patients who have failed more than one thing, right? So I think it's, you know, comparing the patient selection is also crucial to comparing.
Catherine.
You said there were differences between males and females. How did that translate into the patients and whether they had recurrences of VT or not?
Yeah, so the great question, asking about male-female differences. So in mice, we can see that even at baseline, there's actually more heterogeneity between male and female mice than there is between irradiated and unirradiated tissues. So keep that in mind, right? So we have to compare changes in females and changes in males separately, though the changes were happening in the same way. Unfortunately, in our human studies, guess what I'm going to tell you? There aren't a lot of women. And so this is I'm glad you asked the question. It'd be really interesting to know. So please enroll women in your studies. You know, so for whatever reason, we have very few women, but there is a similar signal in the very few women as in the men. But I do think these are all very crucial things for us to keep in mind. You know, the underlying biology, at first we were really excited because we saw these differences, but I realized that the changes, if you compare where you start and where you end up, the same pathways are changing, if that makes sense. So I think it's just that we start from a different place. But
And the modulation that you talked about in the latter part of your talk, are you suggesting that's a new therapy that'll be added into patients in CCU after an infarct? Besides the and other things, they get a low dose.
Okay, okay, so from a scientific standpoint, is it theoretically possible? I think so. Could you consent a patient who's had a large infarct to undergoing radiation? Well, our FDA will say, we want to see the long-term safety data, right? So as a practicing physician at this very moment, I would not feel comfortable delivering radiation to a patient after an infarct without knowing where they're headed, without seeing long-term safety data, right? Because just keep in mind, we just started irradiating hearts, 2016, right? That's not that long, not that many patients. And I think that just like everything starts out where you first do it in the sickest of the sick and it's for palliation, you learn more. And then you can take that into a less sick patient population, perhaps maybe first line, right? Instead of second line therapy. Why fail a catheter ablation, in select patients, right? Maybe in some of these congenital arrhythmias where you can't get there with a catheter, right? And then we get longer term data. Also, I think the large animal models have a role here too, right? Because a lot of those patients are going to live 10, 20 years, right? Like after an infarct. So we do know that there are toxicities from radiation. Now, most of the toxicities that we know about are happening after cancer treatment, which is very, very different because that is lower doses, but many doses, right? So 25 fractions spilling over onto the heart is a very different biology than one large dose, okay? So we can't just extrapolate the toxicities that we know about from fractionated radiation. So I think as a physician, I am not yet comfortable recommending that without more information, but it is something that could potentially be used in the future to modulate scar if we understand the downsides a little bit better.
I have a question. Radiation is a pretty blunt tool. So, and you're seeing these, useful upregulations in channels. Do you think that it is just a fortuitous upregulation just because of the way the genome is arranged? Or is this a response to injury that maybe we could use other tools other than radiation?
Yeah, that's a really great question. I hope you all heard it. It's a blunt tool. Why does it work? And can we use what we're learning to develop something less toxic, which, of course, the radiation oncologists wouldn't like. But I actually even think about it as, could we have an adjunctive therapy that would allow us to kind of loosen the chromatin maybe and give a lower dose or something like that? So there's active things that are going on in my lab right now are asking whether these sites of the chromatin changes are happening where the DNA damage is, or is it as part of the repair process, right? So one hypothesis is that, the way the chromatin is packaged in the cardiomyocyte makes certain areas more susceptible to the damage itself. I did show you that these changes are happening everywhere in the heterochromatin and the euchromatin. So I kind of think it's not the case, right? And also where the damage is hitting is pretty nonspecific. It's like a Mack truck, right? Hitting the chromatin. So I think, me personally, and I don't have good data, but I'm working on it, is that it's part of the repair process of why it's so coordinated and happens the same every time. And again, that would go along with the fact that this doesn't happen instantaneously. It happens over time. And I think that's the repair process. And so yes, maybe we could find less blunt tools to damage the DNA. I showed you bleomycin, but I wouldn't recommend it, and that's why actually one of my radiation oncology colleagues said, oh, please don't show that, because then people are going to start saying, oh, I'm just going to give patients bleomycin. Don't give bleomycin to do this. It's not, this is just but to your point, I think that'd be the gold standard, right? The nice thing about radiation, though, keep in mind, is it is a blunt tool, but you can deliver it exactly where you want. And that's pretty cool, right? Because a lot of the tools we have in cardiology work, but we just don't have a way to get it there without cracking someone's chest or, getting it there at a high enough, viruses can't get there at a high enough, multiplicity of infection to actually like do what they need to do. So there's that part to it, right? It's localized. So.
Thanks for a great talk, and very, very interesting and compelling data. I guess, so a lot of your talk implied that these changes are happening actually in healthy myocytes, basically. I mean, obviously the scar tissue, the scar cells, you can't upregulate a dead cell. But it implied that with scar-related VT, you've obviously got an inner loop within the scar and an outer loop in healthy myocardium. And perhaps affecting that outer loop of relatively healthy myocardium may be one of the ways that VT is prevented by increasing that conduction velocity. Does that imply that being less strict in your radiation volume may actually be a benefit rather than a drawback? So if you're taking in a little more cardiac tissue around a scar, maybe your conduction velocity changes are even better at preventing VT.
That's a great question. So the question was, if it's not if we're modulating, healthy tissue as well, does the dose prescribed to the healthy tissue matter? I think yes, and maybe matter more. That's exactly what I'm trying to study with our animal models. So we're now changing in a very prescribed way the dosing strategy. So we're de-escalating. But in that de-escalation, we're also kind of comparing the different ways of delivering it. And I really think it matters of like, here's where we deliver it and here's the effect. And so I think we need the computational modeling because just the speed. And so we can go from the wet bench, say, if this is what is happening, what would that predict should occur, and then see if the reality measures up to that and how much do we still not know, right? And then, I think that ultimately, I hope that we can use computational modeling as a way to kind of predict the outcome before we do it and say, maybe we need to tweak this in the plan. So I don't think the initial targeting was with the mentality of making a scar. And so if you're trying to make a scar in a focal area, you don't care about all these other things. And that's what I'm suggesting, is that we should care about those other things too.
And by computational modeling, do you mean taking a patient's MRI data of their scar volume and distribution and using that to predict the VT circuits and treatment?
Exactly. I mean, doing this. So we did this for our pigs, where we can, look at, so this is the actual pig MRI, and we can look at the scar, and we can, look at the, let me see. So, induce VT computationally. I don't know why. There we go. Okay. So you can pace, from different areas, and then induce the VT, and then say, okay, now I'm going to change the properties of this tissue in this way. So in this area, I'm going to change the properties. I'm going to change to conduction, and this change to refractive period. And then, so this will require like knowing the optimal strategy computationally, and then saying, what is radiation actually doing? And so that's what we're trying to do. We're actually doing that right now. We're making all these measurements and trying to predict what will happen. But I completely agree that what this area gets could be very relevant, and since we don't think we're just ablating away this tissue right there.
Yeah,
Last
statement
question.
is very fascinating, making me thinking a lot. So radiation to me, I always associate with mutagenesis. With radiation to generate mutants. So then besides radiation, besides changing the chromatin accessibility, have you checked whether the radiation at your condition, in the mouse or maybe in the pig, leave them for a long time and check whether you generate any mutations? Have you like get the tissue and whole genome sequencing?
It's a really great question. And so the question was, do we generate mutations? I'm sure that the answer is yes. I've been told from my radiation oncology colleagues that there is no quote unquote safe dose of radiation, right? It's just a matter of like risk and benefit. So it's actually not as easy. You can't just whole genome sequence, because keep in mind, it's not happening the same in every cell. Every cell has a different so you got to do this on a single cell level, right? Because the mutation generated in one cell could be different than the mutation generated in the neighboring cell. So, but to answer your question, what happens in dividing cells is very different, because they use homologous recombination to repair. And so if you hit a dividing cell with a high enough dose, the lower doses will cause senescence, higher doses will cause apoptosis. And in fact, the endothelial cells disappear and come back, right, in the heart. But for non-dividing cells, they use non-homologous end joining, which is, going to have some, mutations, but it's very efficient at repairing. So the question is whether over 10 years, right? Because in cancer patients, sometimes you get a secondary cancer 15 years after your radiation because of the secondary, mutagenesis, right? So you take that risk because you're going to die. I'm going to get radiation and live. And I know that 15 years later, I might have a secondary cancer. So that's what I'm trying, the question that I was asked, would you then start irradiating post-MI patients? I don't know. I'd kind of like to see a little bit longer data to see what happens, and in these patients who we're treating right now, their lifespan is 3 to 6 months, right? And they're getting shocked 100 times a month. They have a very low quality of life, right? They've failed everything else we can offer. So it's a very different thing to take a 40-year-old who has an MI, right, and who we don't know where they're going to end up, and prophylactically irradiate them. I'm not saying it would never happen. I'm just saying that there is the potential to do harm. So I think we need to be careful about that before we just, go about irradiating everybody.
I think we'll close it there. We're running over. So thank you very much. That was a really fantastic talk. Thanks.